Try to make this quick. Start with the case presentation. This is a 5-year-old boy. He has 6 months history of worsening left thigh pain, pain worse at night. No history of trauma. It's starting to interfere with his activities, and NSAIDs have helped with the pain but have become less effective. So on physical exam, he has an antalgic gait, no obvious masses, really non-tender palpation, and full range of motion of the hip, knee, and ankle. On x-rays, on first glance, really nothing super noticeable, but on further glance you can see this cortical sclerosis on the distal lateral femoral metaphysis, and on CT scan, again a rim of a sclerosing rim. Bone scan, it has increased uptake on bone scan. So they did a CT guided biopsy in RFA, observed in a hospital overnight for pain, and was discharged the next day with just Tylenol and no activity restriction. On histology, it had some irregular trabeculae, osteoid, and fibrovascular stroma, which was consistent with osteoid osteoma. 4 weeks after the procedure, he was pain-free and participating in regular activities. So today I'd like to talk about osteoid osteoma. This was first described in the 1930s by Dr. Henry Jaffe. He was a prominent pathologist and described many other bone diseases such as osteoblastoma, giant cell tumor, and eosinophilic granuloma, just to name a few. This osteoid osteoma is the most common benign bone-forming lesion. It accounts for 10 to 12% of all benign bone-forming lesions, and it's 3% of all primary bone tumors. Has a peak incidence in the second decade of life with a range in the epidemiologic studies from 5 to 25 years old. Predilection for males 2 to 1, and a majority of the cases are in the metaphysis or diaphysis of the long bones, especially the femur and the tibia. Other sites can include the spine, upper extremity, pelvis, sacrum, ribs, hands, and feet. On gross appearance, it's typically less than 1.5 centimeters. It has this discrete central area called the nidus. It's surrounded by dense sclerotic bone tissue. There we go. Histologic appearance, it has these thin seams of osteoid or woven bone lined with osteoblasts. Osteoclastic bone reabsorption occurs simultaneously and causes this clear space around the nidus. It's not locally aggressive and thought to have no potential for malignant transformation. So here's the one histologic example, and you can see you have the nidus here, and then this would be rimmed with osteoblasts, same with the trabeculae in the nidus, and then you have this clear space around the nidus where you have the osteoclastic activity. Here's a histologic sample of within the nidus, and you see these trabeculae lined by osteoblasts pointing out with the arrow, and then the arrowhead is pointing to capillaries, which the nidus is very dense with capillaries. So thinking about the differential diagnosis for this, it's really 3 major ones. Stress fracture, which you can see that sclerosis, but you normally don't have the nidus. Brody's abscess, again, you can have the sclerosis, and sometimes the nidus. Bone scan sometimes can help you differentiate that, as Brody's abscess normally doesn't have the double density sign. Then osteoblastoma. So the reason that they think that this causes so much pain, the nidus contains these nerve fibers near these capillaries and arterioles. Then you have upregulation of the the COX proteins, which increases your prostaglandin synthesis. And then pain directly from the prostaglandin production, just as it increases inflammation, usually seen worse at night and with alcohol intake. And then also this prostaglandin is thought to indirectly cause pain by vasodilation, which stimulates these nerve endings due to increased blood flow. So symptoms include, like we talked about, night pain. This is typically relieved with NSAIDs because these inhibit the prostaglandin production. You can see local swelling and muscle atrophy, tenderness, palpation, gait disturbances, especially if it's in a weight-bearing location. Leg length discrepancy. Dr. Pazer examined or reviewed 4 cases and found in patients with osteoid osteoma in the femur or tibia had an average of a 12 millimeter leg length discrepancy, with the affected leg, the leg with the lesion, being longer. And it's thought to be that this is due to hyperemia near the growth plate that increases growth at that area. And you can also see joint infusion if this is an intra-articular lesion. You can also see scoliosis. It's normally on the lesions on the concave side of the scoliosis, and it's thought to be that this causes muscle spasm, and the pain from the osteoid osteoma causes contracture or spasm of those muscles, and leads to rapidly painful scoliosis, rapidly progressive painful scoliosis. On imaging, plain films can show the cortical lesions, which is usually just an oval radiolucency surrounded by this reactive bone sclerosis. And then bone scans are very sensitive, but they lack specificity, and they show an increased uptake by the nidus. And then this double density sign is really this increased uptake of the nidus and also increased uptake of the reactive sclerosis. So you get two areas of increased uptake. Brody's abscess, on the other hand, would just have increased uptake of the reactive sclerosis, and then the center of the nidus, or where the chronic infection is, would be a photopenic or no increased uptake. CT scan is really the imaging modality of choice. It shows this low attenuation nidus or darker area in the center. Sometimes this can have mineralization, and then varying degrees of sclerosis surrounding the nidus. MRI, on the other hand, really isn't as helpful. The lesion appearance is very variable, has these associated soft tissue changes and bone marrow edema. And in one study comparing both MRI and CT scan, they took 19 cases with biopsy-proven osteoid osteoma. They had 3 blinded radiologists review these cases. 12 of them had preoperative MRIs, 7 had preoperative CT scans. And then the correct diagnosis was made 2/3 of the time in the CT scan, but only 3% in the MRIs. And then this was labeled correctly as benign in just over 80% in the CT scan group and just under 20% in the MRI group. So they recommend that CT scan be the imaging choice, study of choice, and that MRI scans can be misleading in the diagnosis of osteoid osteoma. So for non-surgical management, the hallmark is NSAIDs. There are really a paucity of literature describing cases and looking at cases of how long it takes to get better, or what time frame you can expect patients to get better, what percentage of patients even do get better just with non-surgical management. This one study found from 1992 showed an average of 33 months of symptom resolution. And there's also some question of sporadic case reports of transformation of the osteoid osteoma into an osteoblastoma. That's, I think, debatable. So surgical management really is for the severe pain, unresponsive to medications, or they have a contraindication to NSAIDs, or if you have a concern for growth disturbance or scoliosis in the skeleton immature. Surgical methods include open excision, a CT-guided percutaneous excision, or a CT-guided radiofrequency ablation. So open excision, you take out the lesion, you can shave away some of the cortical and curettage of the nidus. The challenges are identifying the lesion sometimes can be tough, which leads to incomplete resection. And if it's a weight-bearing bone, you normally have to restrict their activities post-operatively. CT-guided percutaneous excision is a technique where guide wire is put into the lesion under CT guidance. Then usually the cortex is drilled. And in this study by Fenichel, he then took a cannulated curette that was taken down to the lesion, and then the nidus was debrided through the curette. And he showed in 18 patients that 16 got immediate and long-lasting relief. And the 2 that didn't, they believe that on postoperative imaging, they found that the nidus was missed, and they said it was an intraoperative interpretive error, and they repeated this procedure, and that was successful. Minimal complications. They had one complication of femoral neopraxia, which resolved for a acetabular lesion, and then skin abrasion that healed fine. And they did find that comparing their results to the literature, that they found about a 65% diagnostic tissue rate for their biopsies, compared to RFA is usually anywhere between 30 and 50%. CT-guided RFA, though, has kind of become I want to call it the gold standard, but the treatment of choice. And it's an RF probe, or radiofrequency probe, is introduced through a cannulated needle into the nidus under CT guidance, heated up to 9 degrees Celsius for 5 to 6 minutes. Minimal reported complications, minimal post-procedure restrictions, and then biopsy is diagnostic. Most papers quote anywhere between in the 40 to 50% range. There was one that was high as 72. So here's just a picture of the one type. This is the cool tip RF, and then CT imaging of it in the nidus. So Rosenthal did a retrospective review of 263 patients. There were only 2 complications. One had cellulitis, superficial cellulitis. One had a sympathetic dystrophy. Really, only restriction or was the avoidance of strenuous sports for 3 months in patients who had lesions in weight-bearing bones. At 2 years follow-up, they were able to get 126 patients to respond to their questionnaires. They found 117 were pain-free. 9 were unsuccessful, meaning that they still had pain or that they had a secondary procedure at a different hospital for the same lesion. And when they reviewed these 126 patients who were successful, they reviewed how many had a diagnostic biopsy and how many had a non-diagnostic biopsy. They found no difference in the success rate, 90% in diagnostic biopsy, 86% in the non-diagnostic biopsy. So they kind of claim that the imaging and history can lead you to the diagnosis, and you really don't need a positive biopsy to make the diagnosis, and it doesn't really matter with the clinical outcomes. Earlier, in 1998, he did a retrospective comparison looking at the RFA group versus open excision. 125 patients, 38 with RFA, 87 were open excision. There was no significant difference for recurrence. There was 9% open, 12% RF. The only big difference that he found was that the hospital stay was less than a day in the RF group versus about 5 days in the open excision. Diagnostic biopsy was 60% in the open versus 65% in the RFA, so no difference. They found no complications in the RF group and 2 minor complications in the open group, which I believe were just superficial and skin and surgical site infections. So in summary, this is the most common benign bone-forming lesion. Highest incidence is in the second decade of life. Round oval lucency with surrounding zone of dense reactive bone. No malignant transformation potential. CT is the gold standard imaging modality. Typically responds to NSAIDs. And then your surgical options include open excision, CT-guided percutaneous excision, and then I think what a lot of people are moving towards is CT-guided RFA. This quick OIT question. 6-year-old girl comes in with pain for 8 months in the mid-tibia region. She's tried NSAIDs, no longer helping. Pain is severe enough that it's limiting her activities. ESR, CRP, and CBC are all normal. Radiographs and CT scan and a biopsy result are diagnostic of osteoid osteoma. So she goes on to percutaneous RFA. And my references, thank Dr. Bergman, Dr. Eward. Open up to discussion. I guess discussion points 1, I found a lot of debate on if osteoid osteoma really could progress to osteoblastoma if not treated, if treated conservatively. A lot of the paper, or one paper out of the French group that reviewed 2 cases reports that they published before that it was just an osteoblastoma caught early.
So I mean, we can let the 2 people who know much more about this than I can comment on this in a moment, but how do you tell the difference between, like an osteoid osteoma has a nidus of a certain size, right?
Mm-hmm.
What size?
It's like, well, I think it's less than 2 is a demarcation, but it's like less than 1.5.
Yeah, 1.5. And then if it's 1, so that's okay. And then if one's 2, they call it an osteoblastoma, right? Or 2.5.
Mm-hmm.
But they kind of look exactly the same, but a different size of the nidus. How'd they come up with that number?
I'm not sure. I guess that they followed the ones that were bigger and they had a higher chance of being aggressive.
No, the pathologist just decided that's what they were going to do. It's a little bit like what you call normal kyphosis when someone's staying inside, depending how you bend or straighten out, it changes the amount of kyphosis. It was Christian Uni Christian. What's the guy's name? Yeah, he couldn't figure out anything, so he just came up with a number. I talked to him about it because to make a decision. So I think a lot of the confusion about the differentiation in osteoblastomas comes from that, because he just decided size because they needed to classify them one way or another. So it really isn't based on good outcomes. Certainly something that's really big is an osteoblastoma, something that's really small, an osteoid osteoma, but they just he just decided they would make a demarcation in the middle. And the reason I think they probably don't progress, would be my guess, is that what happens if you don't do anything with them? Osteoid osteoma. Leave it alone. What will happen?
Eventually, looking at that one study, they should kind of burn out.
Goes away.
Mm-hmm.
So it's probably unlikely that they'll get bigger. I don't know, these guys may completely disagree.
I think that's one of the most important points, is that they do burn out, but it's important to know, that average time, 33 months, you've got to make sure the parents know that they might be waiting a long time.
It comes down to how much, what kind of symptoms the kid is having. If they have pain every day and they can't do the things they want to do, and they need to be on chronic non-steroidals, and they're that's going to drive treatment. If they really bothers them very little, it's okay just to watch days.
They've all sorts of weird clinical presentations. I've seen all sorts of bizarre things over the years. If it's I've seen one in the elbow joint that presented elbow fusion, one in a pedicle that presented as actually a radiculopathy. You can get really strange presentations, so you have to have a high index of suspicion for